Opioids are grouped into two classifications based on the efficacy at the mu opioid receptor sites that causes analgesia and pain relief. A full agonist has highest efficacy at the mu receptor site. Morphine, heroin, hydrocodone, and oxycodone are full agonists. Codeine is a weak agonist with less than maximal effect with complete receptor saturation. Partial agonists can displace full agonists from the mu receptor site, reducing their effect. Buprenorphine is a partial agonist. Buprenorphine is not easily dissociated from the mu receptor. This is true for an individual taking buprenorphine who also takes a full agonist for a high. The high will not occur since the buprenorphine has such a strong affinity to the mu receptor. Antagonists such as naloxone block and can displace agonists such as heroin, oxycodone, hydrocodone, or morphine from the mu receptor site. There are no opioid effects with antagonists. Naloxone will not induce analgesia. For individuals who experience opioid overdose, in which the mu opioid receptor has been highly activated and respiration cease, naloxone is the treatment to disassociate the opioid from the mu receptor so that respirations may be resumed. Suboxone contains both buprenorphine, a partial agonist on the mu receptor, and antagonist on the kappa opioid receptor, and naloxone, an opioid receptor antagonist. If a person attempted to use Suboxone IV, they would trigger opioid withdrawal due to naloxone component. Opioid effects in adults are categorized by level of occurrence. Opioid use results in pain relief, euphoria, and cough suppression. There may be a high likelihood that opioid use may result in mental clouding, sedation, respiratory depression, antidiuresis, or nausea and vomiting. Likelihood of meiosis, i.e. constricted pupils, constipation, convulsions, or antagonist actions are low to none at lower levels of opioid dose. Buprenorphine, Subutex, is a partial agonist that exerts significant actions at the mu opioid receptor. Its maximal opioid effects are less than that of full agonists and reaches ceiling where higher doses do not result in increasing effect. Because it is a partial agonist, higher doses of buprenorphine can be given with fewer adverse effects, that is, respiratory depression, than are seen with higher doses of full agonist opioids. Past a certain point, dose increases of buprenorphine do not further increase the pharmacological effects of the drug, but do increase its duration of withdrawal suppression. This opioid conversion chart compares equal dosage strength across opioids. Variations in dosage based on route of administration reflect bioavailability of the drug. Parenteral or IV administration requires a much lower dose than oral administration. The dosing interval varies for each drug. Note that the fentanyl dose is in micrograms as opposed to milligrams. There are 1,000 micrograms per milligram. Knowing the dosing interval gives an idea of when a newborn who is prenatally exposed may be showing signs of neonatal opioid withdrawal. Drugs that have a molecular weight of less than 500 grams per molecule cross the placenta. Opioid weights are in the 300s and therefore will cross due to their small molecular weight. Opioids are lipid soluble and easily dissolved in fat and readily cross the placenta. The fetus is in an acidotic state and many chemicals will cross into the fetus. The fetus is able to recycle the drug. After it crosses the placenta into the fetus is able to pee the drug out into the amniotic fluid beginning at 14 weeks gestation. The fetus then swallows the substance in the amniotic fluid, and the substance recycles into the bloodstream. As opioids cross the placenta into the fetus, they attach to the mu and kappa receptor sites. This will in turn cause norepinephrine levels to rise with chronic maternal use. After delivery, when the umbilical cord is cut, fetal blood levels of opioids drop to 0. Increased neonatal norepinephrine levels after delivery cause some of the symptoms of neonatal abstinence syndrome.